All right, we're going to look at a systematic review of CBPHC tonight and its efficacy that our speakers, Dr. Perry and Dr. Freeman, have been working on for the past 10 years. And then we're going to share some stories of how we see these models and concepts in action here at AMOS in Nicaragua. And we're going to have time for discussions and questions at the end. So before we get started on the talk, I just want to do a quick reminder that we're going to be talking a little bit later about how you can sign up for an event that's going to be happening in November, pre-conference for the American Public Health Association's annual meeting. So we'll be talking about that at the end. So remember to stay tuned to figure out how you can be a part of that.
Yes, and I just want to make a little plug for that because Henry and I are the co-chairs for this event. And so anything you hear today, we're just going to discuss a lot more of that in Atlanta on November 4th. So save the date, 8 to 5 in Atlanta, and Henry and Paul and a whole bunch of other people will be there to talk about all the issues with community-based primary health care. It'll be very exciting. We just want to make sure that everybody can join in if they can.
Great, thanks, Dr. Lara. So before we get started, we're just going to do some housekeeping things. We're going to try and get all the microphones on mute from now on so we don't have to hear that. And also, we're going to ask everybody putting their questions and their comments in the chat box. So we know that we have some experts in the field, but we also know that everybody here has a story to tell. So at the end, we're going to open it up for discussion and hear what you all have to say too. So as the talk goes on, please share your questions and your comments in the chat box, and we're going to be compiling them all to go over during the Q&A session at the end. So we want to hear any relevant stories you have, all of your experience with CBPHC, any takeaways you have from the discussion, how you think you can apply these concepts in your work, and of course any questions. Okay, so to get started, I just want to introduce who we have on the call with us today. Since we're discussing community-based primary health care, we're really lucky to have these experts in their field with us. So Henry Perry is one of the authors of the study that we're going to be discussing today, and he's a professor at Johns Hopkins University. And Paul Freeman is another co-author of the Systematic Review of Community-Based Primary Health Care, and he's a professor at Washington University. Between them, they have decades of experience in communities all over the world. So it's really exciting to have them with us this evening. Also on the call with us, we have the founders of AMOS Health and Hope, Dr. Laura and Dr. David Parajón, and they're joining us from Managua, Nicaragua today. So I want to thank all of our amazing speakers for being here today, and also want to thank everybody in the audience for your participation as well. So we have a wealth of knowledge and experience on the call with us today, and that's really exciting. All right, so with that, we're going to go ahead and get started. I'm going to turn it over to Dr. Perry, who's going to give us a background on the history of community-based primary health care.
So, greetings everybody. I'm Henry Perry. I'm very pleased to be here with you today and to talk a little bit about our review that Paul Freeman and I have been working on, as Laura said, for more than a decade now, and has finally come out and finished. Before I really get started on this, I want to quickly mention that whenever I'm referred to as an expert, I like to remember what Warren Berggren said about the definition of an expert. Warren was one of our founding members in the working group on community-based primary health care and had a very dry wit about him. And he told me once that an expert is composed of two quantities, X and spurt. X is an unknown quantity and spurt is a drip under pressure. So I like to tell people that I'm not an expert, but I have a passion for community-based primary health care and its potential for saving lives. And it's been a great privilege for me to be able to work in this area for some time now. I wanted to just say a few words about how we got started on this, and also a little bit about the vision of this at the time of the Alma-Ata Declaration and the International Conference on Primary Health Care at Alma-Ata. So I think many of us know that the International Conference on Primary Health Care had its origins with the Christian Medical Commission and its work on trying to make medical mission work more focused on the needs of the community and moving away from a simple focus just on hospital care and reaching the poor with essential and effective interventions and engaging the commission was all about in the 1960s, and their base was in Geneva, and their work caught the attention of Dr. Halfdan Mahler, who was the Director General of the World Health Organization at that time and had many connections with the leaders of the Christian Medical Commission. And so through that early influence, the top level people at WHO started thinking themselves about a new alternative approach to developing healthcare services that wasn't directly based on the medical curative model of modern Western medical care. And then that led to the Conference on Al-Matah. So the International Conference on Primary Healthcare at Al-Matah in 1978 was the largest global health meeting of its kind up to that point. And Dr. Carl Taylor, again, another founder of our working group on community-based primary healthcare, was a consultant to the conference, working very closely with Dr. Halfdan Mahler, Director General of the World Health Organization, and Dr. Jim Grant, who at that time was the Executive Director of UNICEF. And Carl was one of the primary authors, if not the principal author, of the Declaration of Al-Matah. He never would take credit for it when I talked with him, and I did talk with him about it a number of times, but I know how Carl writes, and I can tell that he was probably the principal author, although many people reviewed it and it underwent many iterations, but his basic ideas, I think, survived this. And the Declaration of Al-Matah is one of the great foundations of global public health, and I like to refer to it as the Bible or the sacred scripture of primary health care, and one of the documents that all of us should read. And if you haven't read it, I would strongly encourage you to download it off the website. Just type in Declaration of Al-Matah and it'll come in. So I lifted up a few points from the Declaration of Al-Matah that have special relevance to community-based primary health care. The point here in section 6, when the declaration is defining primary health care, is that in the bottom of this paragraph, you'll see that it refers to bringing health care as close as possible to where people live and work. I think I saw a circle around that just pop up, but that's a part of community-based primary health care, is bringing health services as close as possible to where people live and work. And then the other key point that pertains specifically to community-based primary health care is the actual mention of community workers as part of the health team, as well as traditional practitioners. But up until that point, community health workers had certainly not been in the mainstream of discussion about health services, and this declaration really provided a green light for programs around the world to begin more seriously about engaging community health workers as part of the healthcare process. At that time in 1978, I don't think the term community-based primary health care existed, and I don't think people envisioned the real scope of highly effective services that actually could be provided at the community level by community level workers. But over the years, as we've had more and more interventions proved to be effective at the community level, and the delivery of services beyond just simply health promotion and referral, as those things have emerged and become stronger, the term community-based primary health care has taken root. So we see here, of course, the basic statements that came out of the declaration as well. which have important relevance for community-based primary health care too. And the ability of having services reach down to the household is a very powerful tool to address health inequities. And we'll talk about this in a minute when we review some of the findings of our CBPHC review. As many of you know, but perhaps not all, we started the working group on community-based primary health care in the early 1990s under the leadership of Dr. John Wyan, who was a close friend of mine and my mentor. And the working group was really geared towards providing a forum for people with interest in community health and primary health care to get together and talk, because these issues really weren't being addressed by the wider annual meeting of the American Public Health Association. And so some years after our working group got established, then Paul Freeman and I started talking about the possibility of reviewing the evidence of the effectiveness of community-based primary health care. And we decided that we wanted to not limit this to any one area, but really focus on the mortality impact that increasing numbers of studies were showing. And so we started putting effort into thinking about how we might carry out a review. And that led to discussions with many people and searching for money. And we made a little bit of progress. We got a grant for $10,000 from the World Health Organization that got this going. And then we got a little bit of support from the World Bank. And we formed an expert panel, and I'll mention more about that in just a minute. And then we brought on board Bahia Razik, who is at that time was a consultant at the World Bank, and Sandeep Gupta, who is a colleague who was working at the Centers for Disease Control, who had a great interest in community-based primary health care, and they agreed to help us on a volunteer basis. And as I mentioned, we had this wonderful expert panel that Carl Taylor agreed to chair. And even though he was getting on in years, he was incredibly enthusiastic about this. And through his leadership and influence, we were able to recruit a world-class expert panel of practitioners, including Roger Rowley and Abhay Bang, and academicians from the London School of Hygiene, Columbia University, and from Hopkins. And then we had people from international organizations, including the Gates Foundation and WHO and the World Bank. And they helped us to set the parameters for our review. And then over the course of a number of years, we started working on a volunteer basis to extract data from articles that we identified that showed whether or not community-based interventions would improve the health of mothers, neonates, or children, as defined by expansion of coverage of effective interventions such as immunizations or use of oral rehydration therapy, improvements in nutrition, reduction in serious morbidity, or improvements in mortality. And so you see that we had this massive effort of screening articles that Paul and I led. And out of that whole process, we identified some 700 articles that qualified for review. And these went way back to the earliest articles we could find in 1950. They included not only peer-reviewed journal articles, but also book chapters and books. And one of the reasons we wanted to do this is that we wanted to make sure that the JOMKED book made it into our review, which is so important and showed a dramatic impact in mortality reduction in JOMKED. And we also included many project evaluations, the most prominent of which were the USAID Child Survival and Health Grants Program evaluations, which all demonstrated major changes in coverage of key interventions. So we had a data selection process that went on, and a data extraction form, 2 different people who extracted data, and then a third person who resolved any differences, and that data went into a database. So this was a major effort with more than 150 people involved. So you can see on the screen here the questions that we set out to answer. And I don't know how effectively we answered these questions, but we tried our best. It turned out to be such a major task to try to pull all this together for such a broad scope of activities. But I'll share with you, and Paul Freeman will share with you just in a minute, what the major themes were of the articles that have just been published. So we tried very hard to collect and record and put into a database everything that was written in an article that concerned the context in which the article or the study occurred or the project occurred, and also to document as well as we could from the evidence written down in the record the actual activities that took place at the community level, the types of workers and the types of engagement with the community. So that was one of the strengths of our review, and according to some people, probably one of the more important parts of our review, since it's very much the case that articles don't generally go into too much detail about how these studies were actually carried out in the field. So we had 8 articles in our series that was published in the Journal of Global Health. That came out at the end of June. The first of the 8 articles is concerned with the rationale for the review and the methods and the data description. So for this and other articles, I just have picked out a couple of key points that I think are worth sharing. And of course, you can read the entire article if you have further interest. But to me, the main points from Article 1 is that there is a rapidly growing evidence of effectiveness, and the number of articles being produced and published every year is growing. And so there's an expanding database that started at a very modest level back in 1950, and has slowly accelerated in terms of numbers of articles becoming available each year. But another important finding from our review is that the great majority of the evidence is based on projects, studies, or interventions that were highly selective, evaluating only 1 or 2 or 3 interventions for a fairly short period of time, 2 to 3 years, in relatively small populations of not more than 100,000 people. So one of the findings at the end is that we need more evidence from larger scale studies with more interventions implemented together for longer periods of time. Go ahead. The second article was on maternal health, and we were able to show that lots of approaches led to improvements in maternal mortality and in more routine maternal morbidity as well. And a lot of these community-based efforts had to do with promoting the utilization of maternity care at facilities, whether it's antenatal care, facility-based delivery, or delivery by a trained provider who was based at a facility. But there were and there have been some other studies that didn't make it in our review because the articles in our review are published up through the end of 2015. So in a sense, our review is already out of date. But there have been a number of articles published beginning in January 2016 on the effectiveness of misoprostol in reducing postpartum hemorrhage, but those were not included in our review.
There's 549 articles which cover child and neonatal health. So what I'm going to do is give you, we're at the stage now where we've collected this data and we're moving on to what does this mean in the real situation. you saw there that we had that most of these studies are what's called efficacy studies. So now I'm talking about these sort of studies and how they're applied in a real situation, which I think a lot of you are working in real situations. So when you come into a real situation, you think of, okay, what can actually be done in these situations? And one of the things is you look, so you look at, resources, what workers are available, what organisation is possible, all those different situational analyses things. Okay, and then you decide, well, what can be done in this setting? And you look at the evidence, and our study is about the evidence. And if you look at the types of studies, we look at these studies and we decide how strong is the evidence. So, for example, treatment of pneumonia in communities. Okay, so we say, okay, how many different studies do we have? What are the different are these studies consistent across settings? How strong are these studies? And then on the weight of the evidence, we decide there's strong evidence that pneumonia can be, for example, managed in the community. But so these studies, quite often they're case control studies or other studies in which the setting is set up in an idealized way so that, in fact, results can happen. You cannot, for example, treat cases of pneumonia if there's not enough drugs, etc. So this is the idealized type of thing. So all these different studies, most of these 702 studies are what's called efficacy studies. They're case control and other types of studies which are not actually the real world. Only a few studies are what's called effectiveness studies, studies in the real world. So what we actually do in relationship to community health workers, community participation, and community management structures decides whether in the real world, whether or not we can get results comparable to what happens in the idealized world. Okay, that's an important thing. Our studies show the idealized world. If we do all these other things properly, in relationship to community health workers, participation and ownership, and community management, then we get the best results. Now, what actually needs to happen in relationship to these different areas really depends on the situation and the resources there. So if you go forward now to the slide you're on before about Article 3, okay, so Article 3 was about neonatal health, and Article 4 is about child health outcomes, okay? And just in summary, we see here the outcome is that all major causes of death in children under 5 years of age can be effectively addressed by well-trained and supported community health workers and effective community-based interventions. Okay, so community-based interventions, in the four things which we talk about in terms of community-based primary health care is what happens at the home visit level, what happens in relationship to community groups like maternal groups, what happens on outreach, and what sort of treatment happens. They're the four things you need to think about in relationship to community-based primary health care. And so we see here, just in relationship, in summary, in relationship to child health, we see here home visits, community-based treatments, outreach, and participatory women's groups. And if you read the actual articles, you'll see a lot of the details. We haven't gone into the details about this. Okay, in relationship to neonatal health, yes, we see here that there are community-based activities which can address the major causes of neonatal mortality, and also there are activities which can address child mortality. Okay, neonatal is the first month of life, basically, and child is from then up to less than 5 years. So now if we move on to the next one, here that's about pro-equity effects. Do you want to talk about that one, Henry? Or
Article 1 was the rationale and database description. Article 2 was maternal health that I mentioned. Article 3 was neonatal health. Child health was Article 4. So Article 3, neonatal health, pulled together all of the available evidence that we could find, and it showed dramatic results in terms of two particular approaches, home visits and participatory women's groups, in reducing a neonatal mortality through community-based primary health care. Very dramatic findings, not only through the Bangs approach of home-based neonatal care, but other activities which are called participatory women's groups, for which there are a number of randomized controlled trials. So we found a lot of evidence for that. And then Article 4 was child health, and then Article 5 was on equity.
so the main thing is for neonatal and child health, there are, and you'll see in the papers, paper 3 neonatal, paper 4 child health. Neonatal we've got is about 80 articles, and child health is 489 articles. You'll see in those two articles that there's good, strong evidence that most causes of neonatal and child health can be addressed. Now, as we progress in the future, new interventions will be found and developed, okay? But the important take-home thing is that no matter how good the evidence that these various interventions work, which usually through efficacy, idealized studies, what really matters, and that's what you'll mostly be involved in facilitating, is what actually happens in the real world in relationship to CHWs, in relationship to community participation, and in community management at that community level.
I mean, one of the striking things about Article 5 is that not only were the effects of community-based interventions equitable, by that I mean that they had an effect that was the same in the low-income groups as in the higher-income groups, but in virtually all of the articles, as you see here, 86.4% of them, they had a greater effect in the lower income groups than they had in the higher income groups. And that's what we refer to as pro-equity as opposed to equitable, where you see 6% of the articles had equitable effects. So this is a very dramatic finding, and there are not that many studies of equity effects of interventions because they require a considerably greater sample size to assess the effects in various income groups. But these findings are particularly important when we think about the very well documented inequitable effects of healthcare utilization and the types of people that come to facilities for services as opposed to community-based primary healthcare. So let's go to the next slide. So Article 6 was on delivery strategies, and I could talk a lot more about this, and Paul has already alluded to the 4 principal strategies that were identified in our review: home visitation, participatory women's groups of one kind or another, including care groups and participatory learning and action groups, the management of serious childhood illness by community health workers at the local level, and also the 4th one, which isn't on this slide, but it should be, is the delivery by mobile health teams of outreach services as these teams that are based at peripheral facilities go out to communities. A lot of their work is immunizations and antenatal care and family planning, but those could be expanded and strengthened too. So as we think about community-based primary health care, we need to think about not relying on one of these 4 delivery strategies, but building them all up to make them all strong. of our database of some 700 articles what evidence there was for a long-term mortality impact. And we queried the database, and we looked for any project or study or program description in which there was evidence of at least 10 years of mortality impact. And what we ended up with were 4 well-known programs in the world of community-based primary health care. The famous JomKed project started by the Arolis in India in 1970. The Matlab Maternal Child Health and Family Planning program started at the International Center for Diarrheal Disease Research in Bangladesh. The Hospital Albert Schweitzer in Haiti with its community-based health program that complemented the work in the hospital. And finally, the Society for Education, Action, and Research in Community Health started and run by the Bangs in India, who are famous for their pioneering work, provided all kinds of services, not just maternal, neonatal, and child health, but a broad range of primary health care services as well as hospital services. They all had a strong community-based program with community health workers, and they had a strong relationship with communities that they worked with. And they all had either they operated themselves or very closely associated with hospital care and curative care at the higher level, including surgery. So, and they had strong family planning programs. So we highlighted all the commonalities of these 4 different programs.
Now we're going to be talking about a case study from here in AMOS Health and Hope. And then later on, when we talk about the new era of CBPHC, that's when we're talking about Article 8 and its findings there. So now I'm going to turn it over to Dr. Laura. And she has a story that we're going to be sharing about one of our community health workers, Agustin, and his community, El Cedro.
Hi, thank you so much. Happy birthday, Henry, too, for tomorrow. And thank you, Paul and Henry, for all your work. We've definitely used that and used a lot of the work that other people have done. And when you're saying, like, how do people on the ground use this? Just so you know, we read all your articles, we read all the stuff, and we apply it here on the ground. So just want to share a really quick story. This is Laura Parajón, just in case anyone just signed on. And I'm the medical director for AMOS Health and Hope, a medical missionary, and basically a student of all those people like Henry, Paul, and many other people on this call. So thank you. We used all the things you taught us. And so this is the reason why we're here. People like Agustin and El Cedro, which is one of our farthest communities. And kind of like when Henry was talking about the pro-equity effect of community-based primary health care, that's why we do it. That's why we love it. We love the fact that you guys have pioneered getting to every single person and you've shown us how to do this in a very real and concrete way. So if you look at some where we are in El Cedro, it's one of the most remote communities we work in. It takes 6 hours by vehicle for us to get there, plus another 3 hours by horseback, 3 to 6 hours, depending on how crazy the rain is. And so as you can see, these are the people we're trying to reach here at AMOS. And community-based primary healthcare, Alma Ata, gives us both the inspiration and the direction as to, like, how do we reach the most difficult to reach people? So basically, one of our biggest issues in these remote areas is we had a very high rate of neonatal mortality. And like Henry said, and also Paul referred to as well, is that how do we do that? It's the package of how do we do systematic home visitation, a community census that actually censuses everybody so we know what's going on with every single mom and baby, use of participatory women's groups, and all those things added together, managing community health workers, working with the Ministry of Health, having good referrals, and having a way to know how to systematically visit every single person has made a huge difference in our communities. One of the promoters had a story where he was systematically home visiting in his area, where, if you can imagine, it's like so difficult to reach. He has to walk 2 to 3 hours just to get to this home visit. And so when he had, a lot of the moms there don't even want to go to the hospital because it's so far away and they have to go by horseback and it takes so long. Augustine finally convinced this mom to have her birth at the hospital, and that was really fortunate because that was one less neonatal mortality because that baby had to be delivered by C-section. So as a result of this work, applying community-based primary health care, really it's like the everyday, to us, it's the everyday commitment and love that people have in their communities to serve the most remote people, to serve the most vulnerable people. What we've seen over time in these communities is that they themselves, working together through the Ministry of Health and through the three-way partnership that Carl Taylor talked about, the government having the top-down, communities bottom-up, and organizations like AMOS coming from the outside in to facilitate, along with all our churches and supporters and donors. It's kind of like, you know, how can you take something, you don't have a lot of money, you don't have a lot of resources, but how do you pull in all the strengths together so that we start seeing childhood reduction of mortality? So we saw over a 90% reduction because of these community health workers and really applying CBPHC. So thank you to everyone for the support of this work that we look forward to keep on continuing to do with the help of everybody. So we want to turn this back over to Henry and Paul. We're very fortunate for your work and all the people you brought together to show us the evidence and show us how to keep on going. So we'll bring this back to Article 8 with Henry.
Yes, the 8th article in the series is an article that was written by the expert panel, and as I mentioned earlier, Dr. Carl Taylor was the original chair of our expert panel, and he died in 2010. So here we are 7 years later in 2017. And before Carl died, he asked Dr. Bob Black if Bob would take over as chair of this panel. Bob was already a member of our expert panel, and he had been the chairman of the Department of International Health at Hopkins for quite a long time. He's now stepped down from that, but he very kindly agreed to serve as the chair of the panel. And so when we got around to finishing up our review, he became the first author of a summary of the findings, but more importantly, the recommendations of the panel itself. As I mentioned earlier, a world-class group of academicians and international organization officials and implementers. And so you can see here from my standpoint, the major two themes that came out of this were that community-based primary health care should become a priority for funding for health improvement. It should be the foundation of an effective health system, not an underfunded afterthought. So that phrase, underfunded afterthought, came in another publication that we reviewed for this work, and it was a great phrase, I thought, because that's basically the way community health and community-based primary health care has been for my whole lifetime. And I think we're getting to the point now where we know that that's no longer appropriate to consider community-based primary health care in that way. And so for many of us, a strong community-based primary health care system is and should be the foundation of a health system, not just an underfunded afterthought. Go on to the next slide. So one of the things I like to say is that to me, we're at the stage now where the science of how to improve the health of populations through community-based approaches is at the point where the practice of medicine in which doctors cared for sick patients was 100 years ago. At that point, we were we were seeing that science could contribute, and there was a scientific evidence for the practice of medicine that was carried out by doctors working with individual patients. And in fact, my grandfather was one of those people practicing medicine at that time who went through this era. And as we have applied the principles of science and learned through science how to make individual treatments effective provided by doctors and the teams that work with doctors, we've made dramatic improvements in health. But now, with this kind of evidence that we brought together in our review, we're showing that so much can be done at the population level by programs that are not provided by physicians, but programs that are provided by teams in collaboration with the communities. And I think we're just beginning to see what can be done, and I'm excited about the future because through further evaluation and through further innovation, I think we're going to see stronger and stronger effectiveness of community-based programs in improving the health of populations. So just a couple of examples of the excitement about this. Just within the last few weeks, countries in Africa have accepted an idea that's just been promoted by the director of UNAIDS, which is that community health workers are the key to ending the HIV/AIDS epidemic. And the basic idea from this is that if we don't have strong outreach to identify HIV-positive persons, and if we don't have the strong outreach programs to get treatment to these people, we're never going to stop the HIV epidemic. And so now within the last couple of weeks in Africa, there has been a new call to train and implement 2 million community health workers. There had been a call for 1 million community health workers, but now bringing in the HIV AIDS component to it, this whole call has been expanded to double that amount. And so we're going to be hearing more about that, I think. It's widely agreed now, I think, that community-based primary health care and strong outreach through that system is essential for ending preventable child and maternal deaths, a global goal now for the year 2030, and also universal coverage of health services is being promoted by the United Nations and WHO. I'm very excited about the new Director General of the World Health Organization, Dr. Tedros Adhanom, who is Ethiopian and who was the real brains behind and leader of the primary healthcare revolution that Ethiopia went through over the last 15 years or so. And Ethiopia has now become a model for Africa as well as for the world in terms of developing a strong community-based primary healthcare program. It's increasingly discussed in things that I hear about and read about that strong community-based primary healthcare programs are needed. And Bill Gates talks about primary healthcare all the time, and they're increasingly focused on integrating community-based approaches as an essential part of their primary healthcare initiative. It's an interesting question for me to think about what the role of NGOs will be in this new era. We know that NGOs have been the engine of innovation that have made all this possible. But as we develop stronger national community-based primary healthcare programs, I think NGOs still have a lot to play in terms of engaging with communities and providing guidance and leadership to governments. So we'll have to see how that all moves forward.
Now that we've heard from our guest speakers on their articles, we're going to move into a bit of discussion time now. So thank you so much for sharing your points. And now we're going to start with a couple questions to our panelists. And then after that, we're going to move into the question and answer portion of the webinar. So if you haven't submitted your comments, your stories, your questions in the chat box yet, go ahead and do that now. And we'll get to them after I ask my questions for our panelists. So the first ones I have to ask Dr. Perry and Dr. Freeman is I know we have a couple of students on this call, people who are interested in starting work in community-based primary health care. So what advice would you give to people who are just starting out, who are interested in careers in this field, on how they should start their careers and start their
So my first answer on this is to try to get out to the field, to be a part of a project or a program that has a strong community-based primary health care component to it. And that's not easy to do, I understand that. But mixing and mingling and sitting down and talking with people who are working in this area is certainly important. And through those kinds of discussions, you might learn about projects that you could visit. And having that personal experience and personal encounter with reality in the field and exciting approaches that are being implemented, such as AMOS in Nicaragua, these are transformative experiences for all of us. And in my own case, my experience early in my career by having field exposure was transformative. And so we've always encouraged people with an interest to get out in the field and to test it out. Another thing I always say is to read the book by the Arolis. Their book, JOMCAD, A Comprehensive Rural Health Project, is one of the great classics of global health. You can order that for $10 or $15 from the Hesperian Foundation, and it's a great narrative of the Arolis' development of the JOMCAD project and the reality of people who are suffering from lack of health care and what can be achieved by working collaboratively with communities and by training community health workers. Paul, do you have anything?
Yeah, I agree with what Henry says. I think well, there's a couple of things. If you're, depends on where you live. I started out in community-based primary health care. I'm Australian and American, but I started in Australia, and my experience of working in community-based primary health care was actually working in Aboriginal health. And you know, they have a unique system there, and which people you actually are based in and live in communities, and you understand the community perspective a lot more than fly in, fly out consultants or consultants based in health centers. And so if you're in the US, you know, and you know, if you it might be valuable for you to be involved with the Indian health services a little bit. The other thing with health services, if you go, for example, at my institutions, there's some people there who say, well, community-based primary health care, it's just not cost effective. Well, you know, you should look into that. You know, this is, and you know, certain major donors don't support it because they don't think it's cost effective. Well, the answer is, you know, Henry's experience and many other people's is that it is cost effective, and that there's also this matter of, okay, there's the dollars and cents, but there's also opportunity costs. And in terms of the evidence, there is no evidence published, and you know, Henry and I have looked at an awful lot of things, that services just based in health centers, which do not get out into the community, actually decrease mortality. Okay? The evidence is lacking in that sort of thing. And yet people, you know, think that, you know, they'll only support things at the health center level. So
Paul, let me just jump in there and just add just a quick statement to that. I mean, that sounds like a very very strange statement. There's no question that the services that are provided to somebody who comes to a health facility, if they're provided in the standard way, are effective in saving lives. But the problem is the people who are dying out in the community who don't come to a health facility. And so there's no evidence that population health, that is of a defined community, has been improved by investing only in a health center, strengthening services at a health center, because of the inequities in utilization of health centers around the world. So anyway, I thought I'd add that. Go ahead. Sorry.
Yeah. I agree entirely. That was the next point I was going to make. For example,
sorry.
Well, it's okay. No, that's fine. One of my earlier studies was on tuberculosis control in Indochinese refugees in Australia, and you find there that to make a long story short, tuberculosis. The patients who come in and are detected as having TB and are treated and supervised in their treatment produce good results. But just as Henry said, a lot of people with, and this alludes to the HIV problem, in a population, a whole lot of people don't come to health centres. And it's not just distance. It's also, their beliefs about the health centre and how they're treated in health centres. And this is also a particularly important thing in these days because of urban health. We know that over 1 billion people live in urban slums in the world, and that's only increasing. So part of community-based primary healthcare is not just rural areas, it's also the big slum areas.
Yeah, so I guess in summary, I'd say try to get some field experience, find out who's around, who's working in this, talk with them, read what you can about it. But the community-based primary healthcare working group at the American Public Health Association and the meeting that we're going to have in Atlanta coming up in only a few weeks in November I'm looking in my book here, but it's November the 4th. That's a great opportunity to be able to mix and mingle with people, and networking and just having a chance to chit chat and visit is so important. And it was important for all of us in our early careers, and we know it is for younger people too.
And also, if you come across papers and people challenging community-based primary healthcare, well, get a copy of the paper and send it over to us, and we'll have a look at it. We have to deal with enemy in quotes. I'm not saying there are enemies, but we need to have an objective approach. And just one last thing. One thing which people do say against community-based primary healthcare, we said that the origins a long time ago were face-based. Well, the evidence now is it's not. If someone says to you, well, that's just some face-based approach, it's not. All the evidence now is that it's scientific evidence. Okay, it's not just face-based groups are doing this. There's it's a major part of of a number of countries. We won't go into it. So it's not just face-based at all.
Well, let's go on to the next question.
All right. Yeah, thank you so much for your answers. And the next question, now that we've talked about sort of how you get your beginnings in the field, we know it can be a very challenging field to work in. So what inspires you to continue your work when things can get a little bit tough? What motivates you to keep going?
Well, I'll be happy to go ahead. So I'd like to say to people that I get more and more passionate about community-based primary healthcare every year that I work in this, because I become more convinced of the power and the potential of it and its effectiveness if it's implemented well in saving lives around the world. And I like to say that the communities themselves are our greatest resource in global health. We get so fixated on money and donors and sort of high-level political engagement and on and on and on. But just like AMOS is doing in Nicaragua, sort of working with local communities and giving them some encouragement and orientation, just with a little bit of expert assistance from the outside, can make it possible for communities to do amazing things and for groups of women to do amazing things. And so over my career, I've seen so many examples of this. And what excites me about all this, among many things, is that we're learning how to do this on a larger and larger scale. And Ethiopia, of 100 million people, they've been able to implement a community-based program that is identical to one we started in Bolivia back in 1981. And we had 10,000 people, and they've applied the same principles to 100 million people. So if we can make that kind of progress, it's really so exciting to think how many lives could be saved around the world, not only of mothers and children, but when you think about the potential of community-based primary health care for addressing other priority conditions that are emerging, such as hypertension and diabetes and mental illness and even disabilities. I mean, we know that so much can be done, and as we get more evidence and more experience and new innovative approaches are tried out, then I think this whole process will continue to accelerate, and it'll be very exciting. So as I get towards the end of my career, I'm just so happy to see the growing interest in this area because, as Paul said, there's been a lot of skeptics out there and cynics and people who didn't really see the value of this. Even at Johns Hopkins, when Carl Taylor started as the chair of our department, and he was working in this area and some pioneering projects, people in other areas of the school were very skeptical that he was doing anything worthwhile. But now everybody realizes he was a pioneer. And so John Wyan used to call me a pioneer, and I call people who are doing this kind of work pioneers, because it's still pioneering work, but it's moving into the mainstream. And as the scientific evidence accumulates more and more, it's going to grow. And so that's what excites me about this.
Well, my comments would be similar, but I mean, I'll tell you my story. My story was I'm from Australia, and I've always wanted to work in global health. So I thought, well, you got to look after the needs in your own country first. So that's how I got involved in community-based primary health care in Australia. And in Australia, they have these groups called Aboriginal Community Controlled Health Services, which really actually started, the Aboriginals started themselves, just started and got volunteer doctors and nurses. And then subsequently the national government supported them. So that's how I started. And then I went to Papua New Guinea, and they needed someone in the university faculty there, so I went there. And then I just saw the need in this area which was being unmet. And I guess because of, I worked for the Aboriginal people for 6 years. I saw firsthand, the difference between hospital-based, health centre-based, and community-based. And of course, in that, dealing with those people, there was and still is a lot of discrimination. And so, that's where I got started. And then it's really just the opportunities flowed on from there. There's a Q&A question about, how can young people who are interested in this area get involved? And I think it's really, you need an ongoing connection, and really the Community-Based Primary Healthcare Working Group of APHA is a good place to go. The other place is Core Group, CORE group.org. Look on there and you'll see a range of organisations, many are faith-based, but many are not, who do community-based primary health care. And you might be able to get internships with them, or at least come to the meetings there and learn about it. So I think and the Hopkins program, I would say that's a good program. Other universities, well, I'm not sure. I really don't know in depth about any other universities.
Okay, so it looks like we're moving into answering some of our questions from our attendees. So Thank you for your answer for that question. We have another one that comes from Kate. She asks, much of CBPR, which is community-based participatory research, is being done by people who are already interested. So how do we get governments and policymakers to become interested?
So the question is, how do we get government leaders and policymakers involved in this and supporting it? So one of the exciting activities that I'm involved in right now is the International Institute for Primary Healthcare in Ethiopia that's been funded by the Gates Foundation. And the purpose of this institution, which is just beginning and getting underway, is to bring people from around Africa to Ethiopia to see firsthand what Ethiopia has done in primary healthcare and to learn about primary healthcare more broadly as well. So being a part of training opportunities where you can go and visit and see in large scale programs, I think is going to be important. And of course, the Institute is especially for higher level people, government leaders, politicians, parliamentarians, to come to Ethiopia to interact with their leaders and see what is going on in the field. I think that's a very powerful experience that can be transformative and motivational, as well as the scientific literature. So we hope that our review will be a small part of changing the opinion about the importance of this.
Yeah, I think that it's not an easy field because there's all these other players competing. So we have to compete for funds, and to change the opinions of funders, etc. You know, that's our study produces a lot of evidence. So policymakers make a lot of decisions on the basis of evidence rather than hearsay, understandably. And so that's where our sort of work goes in, and where if you're going to do an MPH and get involved in research yourself, it can actually contribute in that direction. The institution I'm attached to is the Department of Global Health at the University of Washington. And, you know, they do have a primary healthcare program and a good program there. I won't compare them with Hopkins, but that's an alternative if you're based on the West Coast.
Just one other quick comment, and that is that it is encouraging to me that the Gates Foundation is starting to invest in this area, and I'm excited about the future of this because Gates has so much money, and Bill Gates is increasingly enthusiastic about primary health care. And one of the problems has been in schools of public health, the lack of funding for academics like me to work in primary health care. And so it's not taught, and there's limited research done on it. So I think this is going to change. It may take another 5 or 10 years, but I think we're in the beginning of a new era. I talk about the dawn of a new era for community-based primary health care, but part of it's related to funding for academics related to teaching and research on this. And so these activities, as they get stronger, will also lead to changing opinions of leaders in countries, national leaders, as well as policymakers and international donors. And of course, international experts and opinions of international groups like the World Health Organization are derived directly from evidence. And so the stronger the evidence, the stronger the policies will eventually come. But all of this is a slow-moving activity, and it's going to take 5 or 10 or 15 years. But I think we're at the beginning of a paradigm shift.
Yeah, I agree. There should be a breakthroughs in the near future. The other thing, if you mention Gates, I visited the Gates Center. My wife wanted to go around. I live in Seattle, and the Gates group feature there a link to the core group. So if you're, look up coregroup.org, the 80 organizations there, and you'll see that, and go to they've got 2 meetings on each year. That's a good place for you to link in with other people and get different points of view.
All right, thank you so much for your answers. We see we still have a couple of questions coming in. But it's a little bit past 5:45 already, so we're gonna go ahead and wrap up now. I wanna thank you all so much for joining us this evening. We're really grateful for the discussion and so excited about the future of community-based primary healthcare. So for our audience, I just wanna one more time remind you about the CBPHC pre-conference on November 4th in Atlanta. So I'm sure a lot of you might be at the APHA annual meeting anyway. So as you can see in our speakers list, we're gonna have a lot of really great people talking about really exciting ideas there. As you can see, Henry Perry and Paul Freeman will both be in attendance. And a lot of other, experts, if I dare use the term, in their field of primary healthcare. So we're really excited about this meeting, and we really hope that you all can join as well. As you can see, we're going to be talking about more exciting case studies about empowerment, gender, women, and reproductive health, the role of students. I know there's several students on the call today. And really going deeper in the discussion that we've had today on this idea of if it's an underfunded afterthought or really the key to universal healthcare for all.
And if there are any students out there, we're still accepting student abstracts for the CBPHC conference that you can share and get feedback from awesome people like Paul and Henry and a bunch of other people who will be there. So if you are a student, please submit, because it's going to be awesome.
Yeah, so we're going to be sending you information in a follow-up email that you'll get in the coming days with information on how you can get your tickets and submit your abstracts, how you can read these articles, so you can read them also for yourself if you haven't already, and also a survey you can fill out to let us know what thoughts you had about this webinar. So to purchase the tickets, there's the URL there, and again, we'll be sending it out in the follow-up email in the coming days. If you have any questions for us, feel free to email us. And again, we'll be sending out that follow-up email to you soon. So yeah, I think that's all we have for tonight. Thank you so much for joining us. And Dr. Laura is going to give us a couple of closing thoughts here.
Yeah, I just wanted to thank so much to Henry and Paul for taking the time to doing this webinar and getting excitement out for CBPHC. We hope to share this with more people. And we're just excited to be part of that community. So thank you guys so much for being a part of this, and hope we can continue to work towards health for all.
Laura, thank you for inviting us. It was a pleasure.
Right.
Thank you very much. It was good fun.
All right, thank you. All right, we'll see you soon.
Good night.
Good night. Bye.
Bye-bye.